This is a talk given at the Michigan State Medical Society on September 29th. My name is Carl Christensen. I'm a clinical associate professor in psychiatry and obstetrics and gynecology at Wayne State School of Medicine in Detroit. I have no financial relationships to disclose. I'll be making an updated copy of this presentation, and this is my email address if you want me to send you an updated PowerPoint and link. And this part of the talk, the recorded part, is going to be focusing on treatment of chronic pain, and the other topics covered that day at the Medical Society will not be recorded. So the first thing is, if you're someone like me that's been treating pain, I know that pain is related to an injury. However, the International Association for the Study of Pain has a new definition that came out in 2020 that said it's an experience. It's an unpleasant sensory and emotional experience that is associated with tissue damage or potential tissue damage or resembling tissue damage. So there's a wide spectrum there, but it's an experience that is sensory and emotional in nature. And pain is not an objective measurement. The measurement of pain as a score from 1 to 10 is really not adequate, and we should believe the patient if the patient believes that they are experiencing pain. So if the patient feels they're in pain, they are. But, and there'll be a lot of buts in this talk, there are reasons that a patient may tell you they're in pain that they may not actually be in pain. And why would that happen? One is that they are looking for secondary gain. So they have either an injury or they're making up an injury in order to get out of work or get disability or get off of school. They may be what we refer to as chemical copers, who are not actually people who have an opioid use disorder, but they get benefits from using opioids, and that's due to the effect of opioids on our endorphin receptors. They may have a substance use disorder, so they are what we would say is addicted to opioids, or they may be diverting them, which means they are not taking them, but they are either hoarding them or giving them away or selling them, which are all not going to be good uses for opioids. And pain is classified as an acute and chronic condition. Acute is typically less than 3 months, which includes more than 4 weeks. Subacute pain, and that's occurring during the period of injury and healing. And chronic pain is usually categorized as more than 3 months when the injury is healed. And acute pain is a symptom of another condition. So it's typically a symptom of some type of injury, trauma to a tissue or a nerve or a burn. But chronic pain, as we're going to be discussing, is actually a disease in itself. And another definition to look at, which is in the ICD, the International Classification of Diseases, the 11th version, which is not yet being used in the United States, is primary and secondary pain. Secondary pain is explained pain. So there's an underlying physical condition that causes it, either arthritis or a nerve compression or spinal stenosis or rheumatoid arthritis. But primary pain, especially chronic primary pain, is where there is no clear underlying cause or the pain appears to be out of proportion to the injury. And they're not mutually exclusive. You can have both, but chronic primary pain is believed to be the most common type of chronic pain that exists, as opposed to secondary pain, which has a structural explanation. Chronic primary pain also can exist in more than one location. It can move from location to location. It can move from side to side, and it is characterized by the 2 Ds here, distress and disability. So it's a patient with often multi-location pain, suffering emotional distress, and also suffering from functional or financial disability. Secondary pain, which again is something that someone like me is more used to, can be related to cancer, post-surgical pain, traumatic musculoskeletal, abdominal pain, neuropathic pain, or chronic headache or facial pain, typically due to injury to the structures in the head. And again, if you're like me, I was trained to recognize that pain is a sensory problem, meaning that as an OBGYN, I was trained to understand that pain was due to endometriosis, it was due to inflammatory disease, it was due to acute infection, it was due to injury to the muscles, the bones in the pelvis, but it also has an emotional component and it also has a cognitive component. And these three things add up to what the patient experiences when it comes to pain. There are also different types of pain. There is the classic one, which is nociceptive pain, which is due to irritation of pain receptors in the body. There's neuropathic pain, which is due to actual irritation or damage of the nerves themselves or the spinal cord. And then there is the new one that's gaining more and more recognition, which is nociplastic pain or neuroplastic pain, which is pain due to the central nervous system. And there's also recognition that pain is caused by withdrawal from opioids, and there is a condition called withdrawal site pain, which is caused by an old injury flaring up when a patient is taken off their opioids. So nociceptive pain is due to pain receptors, neuropathic pain, nerve damage. Nociplastic pain is due to what we're talking about next, which is central nervous system or central sensitization, and then the withdrawal associated injury site pain, which has been documented in the literature to present as increasing pain in the same location where the patient had an old injury when they're tapered off their opioids. And there are a lot of synonyms floating around for this condition. So nociplastic pain may also be called neuroplastic pain. I learned it 20 years ago as chronic pain syndrome or central pain syndrome. Dr. Sarno originally called it tension myositis syndrome. Dr. Schubiner, Howard Schubiner, calls it mind-body syndrome, and the ICD-11 calls it primary pain. And typical examples of this would be fibromyalgia, migraines, chronic pelvic pain, interstitial cystitis, low back pain, and irritable bowel syndrome. So central sensitization is believed to be an underlying cause of nociplastic or neuroplastic pain. And what's happened is the central nervous system is ramped up into a high state of reactivity. And the result of this is your pain threshold lowers and the pain continues even after your injury, whatever the injury was, is healed, and there may not even be a primary injury. The two features of central sensitization are known as hyperalgesia and allodynia. Hyperalgesia is where a stimulus that is not normally as painful becomes painful or more painful, and allodynia is a normal sensation that is experienced as pain. There's another term that doesn't really apply here necessarily, which is hyperesthesia, which is a heightened sensation, a heightened sense that could be vision, hearing, touch, anything. And there are two types of hyperalgesia. The first one is primary hyperalgesia, and the other one is secondary hyperalgesia, which is the one related to the central nervous system. Primary hyperalgesia needs no explanation. Here's a picture of somebody hitting their thumb with a hammer, and you know that after you hit your thumb with a hammer, everything hurts more, and it even hurts to touch when it didn't hurt to touch before. So that is tissue injury, releasing inflammatory chemicals in the site of injury, which makes everything more painful. So let me try and show this in graphical form. We have a graph here of intensity of pain versus intensity of stimulus. And let's say you're in a research study and they put a thumb screw on your thumb, which they actually do, and they start screwing it down, and you don't really feel any pain, but at a certain point it starts hurting, and then as they screw it down farther, the pain becomes higher and higher and higher in this sigmoid curve. So that is normal pain. And then you suffer an injury, you hit your thumb with a hammer, and it's unlikely you're going to let anybody put a thumb screw back on, but if they did, what you would find is the pain curve is shifted to the left. So for a given amount of stimulus, everything hurts more. So it's a leftward shift of the pain curve. On top of that, you have what we call allodynia, and what that means is if you look at the original pain curve, when you put this much pressure with the thumb screw, there's no pain. But now with the hyperalgesia, what didn't used to hurt now hurts. So allodynia is a normally non-painful sensation that becomes painful. And this is primary hyperalgesia due to injury. It can also be due to opioids, which we're going to be talking about, but opioids would be an example of secondary hyperalgesia. So secondary hyperalgesia is typically the type of hyperalgesia that is associated with chronic primary pain. And there are multiple causes for this, and we'll go through each one of them. There is OIH, which is opioid-induced hyperalgesia. There is family history or genetics. There are adverse childhood experiences, psychiatric comorbidities, and psychosocial stress. And you all know that your clients or your patients have increased pain when they become more stressed out. So let's look at each one of these. The first one is opioid-induced hyperalgesia. And this is a condition that's been recognized for a long time. We know for some reason that some patients, when they take opioids, after a while, their pain becomes worse on the opioids. So you wind up increasing the dose, which works for a couple of weeks, and then they're back in the same boat. So you chase their pain with increasing and increasing amounts of opioids. And some of these patients that I've seen are on doses of more than 1,000 milligrams of morphine a day. And one treatment for this is to take the patient off opioids. Another treatment is to switch them to a different opioid, which is called opioid rotation, or to a medication called buprenorphine, which is a partial opioid agonist, which everybody knows is Suboxone or Zubsolv. And this is a study done by Michael Barron down in Tennessee, and they took volunteers who wanted to get off their opioids and detoxified them off the opioids. Some patients didn't get any other opioid. Some patients got buprenorphine. They got Suboxone. And here's what happened to their pain scores. The pain score before detoxing was 8. The pain score after was less than 4. That is a huge difference. That's a major difference in pain management. And if you're like me, the first time I read this article, I said, well, it's not because they came off their opioids, it's because they were switched to buprenorphine. So he went back and looked at the patients who were detoxed without and with buprenorphine and found that the pain scores before and after were not significantly different. So this is the primary effect of taking the patient off the opioids, which is obviously one treatment for opioid-induced hyperalgesia. But you have to realize that while the patient is coming off, their pain is likely to worsen because of withdrawal-related pain. Stopping an opioid will increase your pain, and the patient has to be managed very carefully or they won't be able to tolerate it and they're going to stop their own detox. Another condition or another cause is genetics, and this is a twin study that looked at the percent genetic component for different chronic pain conditions: migraine, dry eye, irritable bowel, pelvic pain, chronic widespread pain, which we would refer to as fibromyalgia. And the percent that was due to genetics goes from 19% up to 46%, which is about the same component you see in other chronic illnesses including addiction, which we'll come back to. Another big cause is what's referred to as ACEs, or adverse childhood experiences. These are conditions that have been documented that when they occur in childhood, which by the way they refer to as under 18, will cause bad consequences later on in life. And there's 10 of them. There's 5 that you experience and 5 that you witness. So if you experience physical, sexual, or psychological abuse, or experience physical or psychological neglect, or you witness in your family domestic violence, drug and alcohol abuse, mental health problems, incarceration of a family member, and separation or divorce of your parents, this is the ACEs, and this is a risk factor for adverse effects later on in life. And there's a lot of them. We know for one thing is that your chance of becoming an intravenous drug user is directly related to your number of ACE points. And this study here looks at 1, 2, 3, 4 or more of those 10 ACEs, and it's a straight line looking at the chance of you becoming an intravenous drug user. Alcoholism, suicide, obesity, other mental illnesses are also increased, as well as secondary hyperalgesia. We also know that chronic pain patients are more likely to have co-occurring psychiatric disorders, depression, bipolar, sleep disorders, personality disorders, addiction, and then all these common psych conditions, anxiety, PTSD, somatic symptom disorder, GAD, and obsessive compulsive disorder all contribute to chronic pain. PTSD is a very important one. It is only found in 3.5% in the general population, but it's found in 35% of patients with chronic pain and in 50% of patients with chronic back pain. And this is a very significant contributor, and is something that you should ask patients about if they're being evaluated either for a substance use disorder or for chronic pain, especially with opioid use. And we're not going to be able to talk about it in this recorded talk, but if you look at the current understanding of addiction, addiction is not just reward. We always think about reward being the dopamine system and the nucleus accumbens, and the nucleus accumbens are inside the basal ganglia, but there's also what we call an anti-reward system that pushes back on reward and makes the patient feel dysphoric and draws them or forces them into continued use. And it gets worse and worse if the patient is in withdrawal, if they don't have their medication. We also know that we have the cortical component of addiction, which is, I'm going to show you later on, related to parts of the brain. What makes your anti-reward system worse? And we're talking here about addiction, but look how many of these we just talked about. Your family history. Epigenetics is also related to drug use. That changes how your DNA works and how your DNA expresses protein synthesis. Psych conditions and ACEs. It really is the same conditions drive hyperalgesia and also anti-reward. They're very closely related. Before we talk about treating chronic pain, we should talk about treating acute pain. And this would be an example of somebody who's being treated for acute postoperative pain. And I practiced surgery for 30 years, and I know deep down in my soul that opioids are the treatment for acute pain. There really is nothing else that works better. Maybe. Here's a study done from Cochrane databases looking at a single dose of different pain medications for treatment of acute postoperative pain. And these numbers here are telling you the percentage of patients that got at least 50% pain relief. So for example, for Motrin 200 milligrams, 37% got 50% or more pain relief. And if you look at the first 3 columns, Here's Motrin 200, Tylenol 500, and Motrin 400, and they're all 30 to 40% effective. And then when you move on to the one that you know is going to work, oxycodone, Percocet, or OxyContin, it's only 20% effective as compared to these. It is less effective for the treatment of acute pain. Then when you combine oxycodone and Tylenol, which is Percocet, then you get a almost doubling of the pain efficacy. And then when you go back and say, let's take these two and mix them together, you get the biggest pain score of all, pain relief score of all. 60% get 50% pain relief when you combine ibuprofen and Tylenol. The kicker is that it needs to be given together. And again, if you're like me, you were trained never to give them together because of side effects. You must always stagger them, which makes them much less effective. Now, your patients, even though they're not getting the same amount of pain relief, may still prefer getting opioids for acute pain. Does that mean they have an opioid use disorder? Does that mean they have opioid addiction? No, because opioids have other effects besides a small decrease in pain. They have an effect on depression and anxiety, and an increase in motivation, reward, confidence, and what we call warmth liking, which is that warm fuzzy feeling you get when you're in some type of social situation. This is all caused by opioids through the endorphin pathway, and it is an added benefit to giving a postoperative pain medication, which is one reason that your patient may like it. And this study here found that the warm fuzzies, which is what I call warmth liking, are mediated by brain opioids, the endorphins. And when you gave a patient naltrexone, which is an opioid blocker, they didn't get the same benefit from the opioids. So this would tell you that what's wrong with giving opioids? They have additional benefits, okay? There's other problems. And this is a study done by Dr. Chad Brummett at the University of Michigan, and he has these huge insurance databases. And what they looked at were patients who were given opioids for acute pain who were what we call opioid naive. And they found that 6% of the patients who were given post-op opioids for acute pain were found to be taking them a significant time of period longer, like 6 months later. And they looked at why patients were taking opioids later on. And what they found was that it didn't matter what kind of surgery you had, which makes no sense. Because, for example, a hysterectomy is much more painful than a D&C, but it didn't matter in this study. The dose of the medication didn't matter, and that doesn't make sense either. What did matter were whether or not the patients were addicted to tobacco, alcohol, or other substances, have mood disorders or anxiety, and what you're looking at are risk factors for chronic pain and risk factors for addiction. So even though these patients may not be considered to be addicted, we know that they may be at risk for developing long-term opiate use, which leads to all kinds of problems. And this is a study done in the state of Michigan, and what they found was pretty much the same thing. If patients were opioid naive and were given their first narcotic prescription, 15% of them were still taking narcotics 6 months later. And that's a big number because there are a lot of opioid prescriptions out there, and Michigan is one of the leaders in terms of writing for opioid prescriptions. All right, let's move on to treatment of chronic pain, and I've put a link here for a talk by Dr. Apkarian, who is at Northwestern here in the U.S., and he has done a huge amount of research on the difference in the brain for somebody in acute pain and chronic pain. And what they found was if somebody is in chronic pain, their brain changes from a acute pain presentation, which is somatosensory, to a emotional pain situation, which involves the same parts of the brain that are involved in addiction. So we go from having the pathway that I learned when I was in medical school. I have a pain receptor that gets stimulated. It goes up my spinal cord, it crosses my spinal cord, it goes to my thalamus, then it goes to my somatosensory cortex, then it turns around and comes down and tells me to pull my hand away from whatever is hurting me. It moves from that to a part of the brain that's involved in emotions, especially fear, and probably one of the biggest culprits in this system is going to be the amygdala. So how are you going to treat these patients? One thing you have to realize if you are even a specialist or primary care provider is that the majority of patients in your practice, probably 85% who have pain, chronic pain, have nociplastic pain. And that's going to be your low back pain, your headache, your fibromyalgia, irritable bowel, chronic pelvic pain, chronic fatigue also, and interstitial cystitis. Opioids don't work for these patients. They work initially, remember, because endorphins respond to opioids, endorphin receptors respond to opioids, and you feel better, you feel warm and fuzzy for a while, but then everything reverses, hyperalgesia takes over, and if you try and taper these patients off their opioids, they need to be aware that their pain is going to get worse during the tapering. We can also use anesthetic procedures. We can do epidural steroid injections. We can do what they call medial branch blocks right into the joints in your spine. You can do radio frequency ablation where you temporarily burn the nerves. You can do surgical procedures. You can do laminectomy. You can do fusions. You can do hardware placement. But these are not believed to give high levels of significant pain relief. And the criteria that is used for chronic pain is that to be clinically significant, it should be more than 30% relief, moderate relief is more than 50%, and substantial relief is more than 70% relief. We don't really see that from these treatments we're talking about here. So that is where someone like me who's giving a talk on chronic pain that I've been doing for years and years will talk about multimodal treatment, and I will give lip service to behavioral health treatments, to physical movement treatments, which would typically be physical therapy, chiropractic, medications, which would be either opioids or adjunctive medications like antidepressants, and procedures like the ones I just listed, steroid injections, radio frequency ablation, and then moving on to major surgery. And we know that we don't usually get a huge amount of relief, and I would say you should also consider behavioral health interventions, which we know patients will typically not be able to engage in. And behavioral health typically involves cognitive behavioral therapy, mindfulness therapy, which have both been shown to have some small effects. But the two that I want to focus on for this talk are pain reprocessing therapy and emotional awareness expressive therapy, which are relatively newer techniques that have, I think, really, really big benefits. So what is pain reprocessing therapy? You need to realize that your patient's brain, which is the source of all pain, by the way, every pain is felt in the brain no matter where it starts, has gone from an acute pain pathway that we understand to a chronic pain pathway which involves more emotion and fear. Pain reprocessing therapy helps patients unlearn chronic pain by retraining that part of your brain. And a major issue is that patients need to learn to not be afraid of pain, which often drives their symptoms. And pain reprocessing therapy first begins with what we call evidence building, which is having the patient go over their own history or reviewing their history with them and showing them that they have a non-structural cause for their pain. And this can be found in any one of the books that I'm going to show you in a second. But basically, the patient learns that their pain is made worse by stress. Their pain may have come on with no underlying cause. It moves, it goes from side to side, it comes and goes without any cause, and treatments that have been offered don't work. And this gives the patient evidence to understand that their pain is coming from their central nervous system and not their peripheral nervous system, their spine or their back. You also teach the patient to learn anxiety and fear reducing techniques, including meditation, mindfulness, vagal techniques, which have been shown to decrease level of arousal. And then the big part here is what's called somatic tracking. It consists of mindfulness, which means when the pain is not too severe, you teach the patient to objectively observe their pain as if they were an observer and not the pain patient themselves. And this is done what they call through a lens of safety. Once the patient is aware that the pain does not mean they are being injured, they're able to do this. And then the patient undergoes a safety reappraisal, and the phrase is, this is real pain, but not real danger. The patient learns that even though they're having pain, they're not being injured, and this is a safe situation. And then positive affect induction, which means replacing the fearful condition when you feel pain with a positive affect, emotion, humor, whatever, when you have pain. And once that's been done, the patient can begin graded exposure to activities that cause pain. At first, they may only be able to imagine doing activities that cause pain, but then they will gradually move on to actually doing the activity that causes the pain. And I want to talk about one randomized controlled trial for pain reprocessing therapy. This is known as the Boulder study. It was done at University of Colorado Boulder by Dr. Alan Gordon, Dr. Schubiner, and other researchers. It was a randomized controlled trial, and patients with chronic back pain were randomized to pain reprocessing therapy, a placebo injection, which was actually an open placebo injection. They told them there was no actual medication in it, but they also told them that placebo effect can occur even if you know that you're getting a placebo. And then they had a control group who were patients on a wait list. And Dr. Schubiner reviewed all the medical records. All the patients involved had abnormal MRIs, but 43 of 45, based on their history and exam and the other items I talked about above, were felt to have non-structural or central type pain. And here's what happened. The purple line are patients who were in pain reprocessing therapy. They underwent 8 sessions with a counselor over 4 weeks, and their pain score dropped from over 4 down to virtually 1. And in the study, they found that 33 out of 44, or 2/3 of the patients, were pain-free or virtually pain-free at 1 month. And they had a pain inventory score of 0 to 1 in 2/3 of the patient. Again, in pain management, that's an outstanding result. You typically don't see anything like that in normal pain management. This is the placebo group and the waiting list, who got a certain decrease in pain, but nothing compared to the pain reprocessing group. And this was sustained. Keep in mind that most clinical studies last about 12 weeks or less. This was carried out 6 months and later on, I believe, to a year. And the decreased pain score was sustained in the pain reprocessing group, and the other 2 groups also sustained whatever pain decrease they got. But this was sustained at least over 6 months. They also looked at brain activity in MRIs, and they looked in this part of the study, they looked at 3 areas of the brain. They looked at the anterior cingulate cortex, the medial prefrontal cortex, and the insula. These areas are all involved with increased activity with chronic pain. The anterior cingulate cortex is activated with chronic pain. The medial prefrontal cortex is involved in emotional and affective involvement with pain. and the insula is involved in what we call interoception, which means what are you paying attention to? And what they found was for the pain reprocessing therapy, all three areas had a significant decrease in pain or activity in the brain sites. And the placebo, the sham injection, had an increase in activity in two of the areas and a decrease in one area, and the usual care group had no decreases in any area. And this is evidence for not only decreasing pain scores, but decreasing pain activity that's being, in this case, being evoked by the patient laying on a pillow and pressing on their back and trying to increase their pain. And we saw decreases in all three areas of the brain. The other technique is emotional awareness expressive therapy, and this is being promoted by Dr. Schubiner and others, and it involves starting off with neuroscience education again and building evidence for a non-structural cause, pain exposure therapy, and cognitive behavioral therapy, and then another technique called intensive short-term psychodynamic therapy, where the patient is really encouraged, I would say, encouraged to express or experience emotional situations or traumatic situations in their past. And one study done at the VA, which compared emotional awareness expressive therapy to cognitive behavioral therapy, which is the one typically used, found that in the cognitive behavioral therapy group, only one patient had more than 30% pain reduction, 40% had more than 30, 30% had more than 50, and 13% had more than 70. So the overall response rate was over 40%, and of those, many had moderate or substantial pain relief by using this technique. Now, what about opioids? Opioids are not recommended for patients with nociplastic pain because of hyperalgesia, opioid-induced hyperalgesia. And if you have a patient who comes to you on opioids, you have several choices, which we're not going to really be able to discuss in any detail. You can keep the patient on the opioids, and if you can get them through some behavioral technique, then they may be able to decrease their dose. You can try and go ahead and taper the opioids, realizing that their pain is going to go up. You can switch them over to buprenorphine, which is what I used to do for a living, which can be difficult, but pain scores typically go down when you do that. And here are resources for your patients that I've listed, that I've worked with. Charlie Johnson is a PhD physical therapist who has a program online, and these links can all be opened up. And he works especially with patients who have severe pain, and before they can become involved in any type of reprocessing therapy, they have to also work with pain reduction techniques, which he calls pain subtraction, or other people would call it pain avoidance, a very good course. The most popular app that's out there is the Curable app. It's available on your iPhone, and if you don't have an iPhone, if you have one of those other ones, it's also available on that. And then you have Alan Gordon and Howard Schubiner, who have written books. Alan Gordon's book is The Way Out, and Dr. Schubiner's book is Unlearn Your Pain. If you go on his website or both these websites, they have a lot of additional resources. And then Lynn Health is an organization online that will set your patient up with a pain coach who will take the patient through a lot of this education and somatic tracking techniques. Now, this is one advantage of this, because when anybody, or including me, heard about using behavioral health, you realize that the resources are really not available in your location, and they're not covered by insurance. These are mostly not covered by insurance either, but they are accessible online. They are safe. They are very relevant and they are very effective for your patient. So you don't have to learn how to do pain reprocessing therapy or emotional awareness therapy. You can refer your patients to one of these websites. I like to finish off with 3 case studies. They're all true with details changed, and see what you would do in this situation. First one is, these are my patients. First one is a 67-year-old with a long history of low back pain. I've been treating her for about the past 10 years. She has a 20 or 30-year history of pain. She's had multiple surgeries and had been relatively stable, but had a recent sacral fracture, had to have it fused, and then had to have more hardware replacement in her back, and her pain was much worse postoperatively with both low back pain, gluteal pain, sciatica. We tried switching to oxycodone. We tried gabapentin. We took her on and off buprenorphine without relief. I sent her back to her pain clinic. She was given epidural steroid injections, physical therapy. She was given a spinal cord stimulator trial. Her x-rays did not show any new surgical problems that would explain that pain. And she is really desperate, and every time you talk with her, she wants a new medication to treat her pain. So what can you do for her? You have choices. You can continue the anesthetic treatments, continue physical therapy, and epidural steroid injections. The spinal cord stimulator is out the window because she failed the trial. We could try and overcome her tolerance by increasing her opioids, by taking her back onto oxycodone or increasing her buprenorphine. We could send her to a tertiary pain clinic and have her start from scratch, or we could refer her to a pain reprocessing therapy program. And what happened in this situation was that she is really not interested in anything besides a structural solution or a medication solution, and she is not interested in any type of pain reprocessing therapy. And what has actually happened is she took herself down to the Cleveland Clinic, and she was offered ketamine therapy, which she is now trying to find locally while she lives. This is a patient who would probably benefit from PRT. The problem is that she believes there is something wrong with her back. Her problem is her back, and that the only solution is something that treats her back or gives her an opioid. And that's the difficulty here. Here's another study. This is a 66-year-old I've been taking care of for, I believe, 5 or 6 years. She has a history of low back pain and sacroiliac joint pain. And when I met her, she was on fentanyl patches, and she was switched over to buprenorphine, which gave her better pain relief. She has a history of uterine cancer almost 30 years ago and was treated with a radical hysterectomy. She didn't need radiation therapy. She did not receive hormone replacement therapy, even though her ovaries were removed. And she has urinary problems after her pelvic nerves were cut with the radical hysterectomy. And she has an episode where she wakes up early in the morning, and she had severe unbearable pain in the mid and low back. She now has urinary incontinence, and she tries to get out of bed, and she falls on the floor, and she actually calls an ambulance and is taken to the hospital. So what would you do in this situation? She could have an increase in her pain medications because her pain is much worse. You could refer her for physical therapy because it sounds like she might benefit from motion activities with her lower back. You could refer her for pain reprocessing therapy because if she's been in pain for this long, you know that this is most likely a central condition and not a structural condition, or none of the above. So what happened in this situation is, this is a warning for misdiagnosing a rapid acute increase in pain. This patient had what we refer to as a cauda equina syndrome. Her spinal cord was being crushed, and she became incontinent because of that. She couldn't walk because of that. Her pain was much more severe, but when she went to the hospital the first time, the hospital staff realized she was on opioids, decided she was drug seeking, and tried to send her home. And she came back to the hospital, insisted on being treated, and once they realized what was going on, this becomes a surgical emergency, and she had to be transported to a different hospital across Michigan and underwent an emergency decompression of her spine. So all chronic pain is not nociplastic. There are structural conditions, and actually one of the first things you do in this situation is you rule out a structural problem. Okay, third case. This is a 70-year-old man with sudden onset of gluteal pain and hamstring pain, starting on the right side, moving to the left side, and then on both sides. He has a history of low back pain. He has a history of diabetic neuropathy. And the significant thing in his social history is he works as an expert witness for the U.S. Attorney's Office, and he had just been involved in a court testimony where he described the defense attorney as being a pain in the ass, which may or may not be significant. He sees his PCP, x-rays show bilateral hip arthritis, physical exam shows decreased reflexes in the lower extremities, but he has had these for decades actually. He's referred to physical therapy, chiropractic. He started on long-acting nonsteroidals. He's given an oral steroid boost twice and does not respond to any of these. And he's becoming frantic because his work involves sitting and traveling, and he has just lost 3 government contracts because he couldn't travel out of state. He can't sit for more than a couple minutes, and he spends the entire day standing and sitting when he wants to be working. So what would you do for him? You could do an MRI, and based on findings which are likely to have spinal stenosis in the MRI, you could perform an epidural steroid injection. You could do an MRI and recommend surgery. You could also recommend a spinal cord stimulator trial. You could trial him on antidepressants or anti-epileptic medications, and this, if those don't work, then you could consider opioid therapy. And the latest government guideline, the CDC guideline from 2022, says that in a situation like this, opioids may be necessary. So take a second and decide what you would like to do. The answer is none of the above. The one extra caveat in this history is this is a doctor. This is me. I went to medical school with Howard Schubiner, and I started, even though I had taken his course years ago, I had put it aside because I specialize in prescribing opioids, and I got involved in 2 of the organizations, Dr. Johnson's and Lynn Health, as well as going through Dr. Schubiner's book and Alan Gordon's book, Dr. Gordon, and I had a near complete relief of my pain. And I was almost certainly heading for epidural steroid injections, possibility of surgery, and a spinal cord stimulator, because the odds that a 70-year-old man has an abnormal MRI are about 80%. And if I had acted on those findings, I would have gone through a long list of medications and procedures and surgery that probably would not have helped. And that's all I have, and thank you for listening.